Hello students, today we're going to learn in detail the last part of odontogenic tumors. Okay, so today we dealing with odontogenic tumors exclusively. So first of all, let's deal about the classification. So why classification is important in MCQ viewpoint is that, so sometimes they will give you some options, okay, choose the benign malignant tumor out of this, or a malignant tumor out of this, or choose the tumor which is of epithelial origin purely, or epithelial mesenchymal origin. So you should be able to classify them. Okay, you should be able to choose the odd one. Okay, so that is the importance of classification. So odontogenic tumors are classified basically into benign and malignant tumors. Okay, so you're classified basically into benign tumors and malignant tumors, okay, by WHO, World Health Organization. That is the histological classification. Now, when you take the benign tumors, they're again sub-classified into three types. The tumors which are purely from the epithelial origin, the tumors which are from both epithelium and the mesenchyme, that is connective tissue origin, okay, from both from epithelium and from that of the connective tissue. And last one, only from purely, the origin is purely from the connective tissue. Okay, so that is how you classify benign tumors. Okay, so most of the odontogenic tumors come under benign category. Very rare, one or two tumors come under malignant variety. So MCQ viewpoint, we have to learn in detail how which cell is coming as the parental in origin. Okay, so the benign tumors, the first one, the tumors under origin from odontogenic epithelium. So the first one is aminoblastoma. Secondly, we have squamous odontogenic tumor. Thirdly, calcifying epithelial odontogenic tumor, or otherwise known as pinbot tumor. Fourthly, AOT, that is adenomatoid odontogenic tumor. And last one, keratocystic odontogenic tumor. So when I had told you in the previous lecture about OKC, odontogenic keratocyst, I had mentioned nowadays OKC is being reclassified into tumor. So OKC is now called as keratocystic odontogenic tumor, and it is put under this category. Okay, under this category of benign tumors under the odontogenic epithelial origin. Okay, clear? Now coming on to the second, under the benign itself, the second subdivision. Okay, the tumors which are originating from both epithelium as well as the ectomesenchyme. Ectomesenchyme means connective tissue. Okay, so they have origin from both epithelium and connective tissue. It includes which all? Ameroblastic fibroma, ameroblastic fibrodentinoma, ameroblastic fibroadenoma, and the ones which I have given in reading, okay, that is complex odontoma, compound odontoma, odontoameloblastoma, calcifying cystic odontogenic tumor, and denogenic Gosel tumor. All these are very, very important. That is why I have given in reading. Okay, so the odontogenic, so these tumors are coming under both origin. Okay, so they have their father as epithelium and their mother as connective tissue. Okay, remember that way. So it comes under which all things? Which all? Ameroblastic fibroma, ameroblastic fibrodentinoma, fibroadontoma, complex odontomas, compound odontomas, odontoameloblastomas, calcifying cystic odontogenic tumors, and denogenic Gosel tumor. Now coming on to the third subdivision, here the origin is purely from the mother. Okay, only from the connective tissue, that is ectomesenchyme. Okay, so those three are odontogenic fibromas, myxomas, and cementoblastomas. Okay, clear? So benign tumors and malignant tumors, this is the main subdivision. And then again under benign, they are reclassified, again classified based upon the origin, purely from epithelium, origin from both epithelium and connective tissue, and third one purely from the connective tissue. Clear? Now coming on to malignant variety, malignant tumors are again subclassified based upon whether they are originating from the epithelium or whether they are originating from the connective tissue. If they are originating from the epithelium, they are called as carcinomas, okay, odontogenic carcinomas. And if the origin is from the connective tissue, then they are called as odontogenic sarcomas, okay, both A and B. Now, under carcinomas, you have a malignant amenoblastoma. Okay, the benign amenoblastoma can transform into a malignant amenoblastoma. Then ameroblastic carcinoma. Okay, a carcinoma like squamous cell carcinoma can origin from the ameroblastoma. So that is ameroblastic carcinoma. Third one, primary intraosseous carcinoma. Clear cell odontogenic carcinomas, ghost cell odontogenic carcinoma. So this subclassification is based upon the cell which is present within them, histologically which all cells are present within them. Then the second subdivision, that is odontogenic sarcoma. In that the malignant variety tumors, the parental origin is mainly from the connective tissue, as I told you. So it includes ameloblastic fibrosarcomas, ameloblastic fibrodentinosarcomas, and fibroodentosarcomas. So whatever I have given in reading, only that is important in the MCQ viewpoint. Okay. Now coming on to the first one, that is ameloblastoma. So ameloblastoma, as I told you, it comes under benign tumors, benign odontogenic tumors, and that too the origin is purely from the epithelium. Okay, so ameloblastoma, the term is given by Churchill, the scientist Churchill. So you should remember the term, the scientist, the Churchill. And also the other name of ameloblastoma is adamantinoma. It can also be called as adamantinoma, and the term was given by scientist Molasses. Okay, so remember these two scientists, Churchill gave the term as ameloblastoma and Molasses gave the term as adamantinoma. And ameloblastoma is purely sometimes, most of the times, it is a multilocular cyst. You can see there are different locus, okay, different circles within the radiographic picture itself. You can see different circles, okay, like a soap bubble appearance you can see. Okay, so that is why it is called as a multilocular cyst, whereas very rarely it is seen as unilocular, also a single circle. Okay, so most of the times it is with multilocular, therefore it is also called as a multilocular cyst. Very rarely they are unilocular in appearance. Now what is ameloblastoma? It's a true neoplasm of enamel organ type tissue which does not undergo differentiation to the point of enamel formation. So in the oral histology chapter, development of tooth, I had explained to you the different stages of tooth development. Okay, in that I had told you the early bell stage is where you have the histodifferentiation. The cells are transforming to ameloblast cells, the cells are transforming to odontoblast cells. Okay, and in the advanced bell stage, from these ameloblast cells we have the formation of enamel, from the odontoblast cells we have the formation of the dentine, isn't it? So during the developmental stage, this ameloblast cell formation is happening. Okay, that is early bell stage is till early bell stage it is proper. Okay, but the differentiation of ameloblast cells into enamel does not happen. Okay, that purely results in ameloblastoma. Okay, so now read the definition once more and see. It's a true neoplasm of enamel organ type tissue which does not undergo differentiation to the point of enamel formation. There is formation up till the ameloblast cells, but afterwards that continuation of the development of the tooth does not happen here. Okay, so the development is only up till ameloblast cell formation. Okay, so that is why this ameloblastoma, that is a characteristic feature of ameloblastoma, and it is a second most common type of neoplasm. It's a second most common type of neoplasm. So which is the first common type of neoplasm? It is odontoma. Okay, in MCQ most of the times people make a mistake, so they ask you which is the most common type of neoplasm among the odontogenic tumors. They give you options as ameloblastoma, they give you options as dentigerous cyst, they give you options as odontoma. The correct answer is odontoma. So most of the people mark it as ameloblastoma, few mark it as dentigerous cyst. So the correct answer is odontoma actually, and ameloblastoma is only second most. Okay, it gets the rank only second. Okay, so it is a second most common neoplasm. Now what is the Robinson's classification of ameloblastoma? That is very important. It is unicentric, as I told you, it is unicentric with a single center, but it is multilocular. Within that surrounding that inside the circle you can see different soap bubble appearances. Okay, different locus you can see. Okay, it is unicentric, it is non-functional. Okay, it is not undergoing, it is not transforming into enamel. Okay, there is no deposition of enamel, only up till formation of ameloblast cells is happening here. There is intermittent in growth, there is difference in the growth rate. Anatomically it is benign. Okay, it is not that malignant. It is purely benign in nature, and it is clinically persistent, and it is visible to you as a swelling. Okay, and it is clinically persistent. So see the clinical photograph over there. The position is in the molar ramus area. So most of the times ameloblastoma location is mandible, okay, than maxilla. Mandible is the most common site, and that too in the molar ramus area. So MCQ viewpoint, remember all these points. Okay, ameloblastoma, the term was given by Churchill. Adamantinoma, the other term of ameloblastoma, was given by Melasses. It is a multilocular cyst most of the times, and very rarely it is unilocular. Then it is the second most type of neoplasm, that also you should remember. First is goes to odontoma. It is unicentric most of the times, and the most common site is mandible molar ramus area. Now coming on to the origin of ameloblastoma is very important. The cell rest of serous. The origin is mainly in the cell rest of serous. Now you will be very clear what is cell rest of serous, because in development of tooth I had explained to you what is cell rest of serous. Is the remnant cells of enamel organ, isn't it? Then Melasses. What are cell rest of Melasses? They are the remnant cells of dental papilla. Okay, so the ameloblastoma can origin from cell rest of serous. They can origin from cell rest of Melasses, from the epithelium of the odontogenic cyst like dentigerous cyst and odontomas. Okay, they can also origin from dentigerous cyst. Okay, and even they can origin from as a disturbance of developing enamel organ or basal cells of surface epithelium of jaws, or from that of any other heterotrophic epithelium, especially that of pituitary gland. Okay, now these are intraosseous varieties of ameloblastoma we were talking about. Now coming on to peripheral type of ameloblastoma, that is the picture which is given in that site. Okay, first picture, okay, with the first arrow mark, it is peripheral ameloblastoma. It is not intraosseous, it is extraosseous. Okay, peripheral type of ameloblastoma which is seen outside and in the overlying alveolar bone. That is the most common location. Now another rare variety of ameloblastoma is pituitary ameloblastoma. Okay, pituitary ameloblastoma, it is otherwise known as craniopharyngioma or Rathke's pouch tumor. Okay, it is seen in the craniopharynx area. That is why the term craniopharyngioma, and mainly in the Rathke's pouch area. So Rathke's pouch tumor. Okay, so that is a rare formation of ameloblastoma, that is pituitary ameloblastoma. Okay, it is not being asked frequently, but still you have to learn. Now another type of ameloblastoma which is seen in the long bones is adamantinoma of long bones, mainly seen in the legs, tibia. Okay, tibia, the bone tibia. You can see in that radiograph it is affecting the bone tibia in the leg, mainly in the leg it is seen. So that is adamantinoma. Ameloblastoma of long bones is seen mainly in which bone? Mainly seen in the tibia. Okay, so these are the rare varieties of ameloblastoma. The origin is mainly from the cell rest of serous or Melasses or epithelium of odontogenous cyst like dentigerous cyst. It can also be, the rare varieties are peripheral ameloblastomas, pituitary ameloblastomas, and that seen in the long bones. Now coming on to the radiographic feature of ameloblastoma, it's very important. They can give you radiographs and they can ask you to identify which lesion it belongs to. Okay, so the soap bubble appearance, the first radiograph. Okay, concentrate on the first radiograph. The characteristic soap bubble appearance is seen, or honeycomb also, you can tell it as honeycomb also. Honeycomb or soap bubble appearance is seen in ameloblastoma. Okay, and in advanced cases, okay, in advanced cases of ameloblastoma, what you can see is the outside the bone will become very thin. Okay, it will be like a eggshell. Okay, so adjacent to that radiograph I have given ostrich egg image. Okay, so the ostrich egg image under high power, this is the view which is being shown. Okay, so you can see small crackling. So this eggshell crackling is the same appearance you can see in the second radiograph. Okay, that which is given in the anterior maxilla region. So it is almost similar to that. Okay, so that is actually resembling the advanced cases of ameloblastoma. It shows thinning of cortical plate, just like eggshell crackling. Clear? Now, which are the types of ameloblastoma which is commonly seen? It is follicular type of ameloblastoma because it has got the highest rate of recurrence. So the first place goes to the follicular type of ameloblastoma. The second rank goes to acanthomatous type. Acanthomatous type is the second most type of ameloblastoma which is seen, and the rarest type of ameloblastoma seen is basal cell ameloblastoma. Okay, that is why I have given as third rank. Okay, the rarest type of ameloblastoma seen is basal cell ameloblastoma. The most common variety and the most recurring type of ameloblastoma is follicular type of ameloblastoma. So remember that way. Remember the mnemonic F1, A2, B3. Then that way you can easily remember F1 the first rank goes to follicular type, second rank goes to acanthomatous type, okay, and third one is the basal cell ameloblastoma, which is rarely seen ameloblastoma, and the other types are desmoplastic variety, plexiform variety, granular cell type variety. So these are the 6 types of ameloblastomas. Under 6 type, you can again, for MCQ viewpoint, you can give a ranking and you can learn, okay, because these 3 are commonly given in the MCQ options: follicular, acanthomatous and basal type. Clear? Now coming on to the surgery part, if you deal with ameloblastoma is mostly removed as surgically, okay, and along with surgery what to do is cauterization is also done, okay, cauterization is also done so that this will reduce the chance of recurrence. Clear? So this is a radiographic picture. The first picture shows the honeycomb or soap bubble appearance. The second picture is showing you the eggshell crackling in advanced cases of ameloblastoma. And along with that, you should remember the mnemonic F1A2B3. This will help you to remember which is the most common type of ameloblastoma among the 6 types. It is follicular type. The rarest form of ameloblastoma is basal cell type of ameloblastoma. Okay, remember all these points. Now in Schaeffer's 8th edition, 2 rarest forms of ameloblastoma is also mentioned. Okay, it is not routinely asked in MCQ. So just know about it. It is keratoameloblastoma. Keratoameloblastoma is actually, there is considerable amount of keratin formation along with the ameloblastic epithelium. So then the ameloblastoma is also called as keratoameloblastoma. Okay, there are subtypes for it. There is papillovirus type, simple with keratocystic. That is PG level, but if you can remember it, it is well and good. But just note down the point, keratoameloblastoma refers to there is excess amount of keratin formation, okay, along with the ameloblastic epithelium. Now another important MCQ is unicystic ameloblastoma. So what is unicystic ameloblastoma? It is, as I told you, the ameloblastoma is mostly multicystic. In the term itself I had given you, it is multicystic. But there can be a chance of rare variety. I had told you there only, I had mentioned there can be a unicystic variety of ameloblastoma. In case of unicystic variety, radiographically you will not be able to see the soap bubble appearance. Okay, here there is only one locus, one center, one circle. Okay, so here there is no soap bubble appearance. It is mostly seen in the younger population. Okay, it is mainly seen in the younger population, and most of the times it is mistaken as dentigerous cyst. In the provisional diagnosis, if you see the radiograph, the clinicians, okay, mostly they make the mistake as dentigerous cyst. Okay, but histologically it will resemble to plexiform type of the ameloblastoma. So if you take a cut section of it and if you see under microscope what it resembles to, it will not be a dentigerous cyst, but instead it will be showing the features of plexiform type of ameloblastoma. So because it resembles to the plexiform type, it can also be called as plexiform unicystic ameloblastoma. Clear? So this is about the unicystic variety. Unicystic variety of ameloblastoma is mostly seen in the younger population. Often it is mistaken with that of dentigerous cyst in provisional diagnosis after seeing the radiographs. Okay, and if you take a cut section of it and if you see under microscope, it will be microscopically it will be showing all the features of plexiform type of ameloblastoma. Okay, because of that it is also referred to as plexiform unicystic ameloblastoma. So remember all these points pertaining to ameloblastoma. Clear? Now coming on to the second important odontogenic tumor, that is squamous odontogenic tumor. Squamous odontogenic tumor is often mistaken as what? Acanthomatous ameloblastoma or well differentiated squamous cell carcinoma. So this is the radiological picture. It is the most common site is mandible. You can see in that radiograph mandible, in the between the premolars you can see the radiolucency in the mandible. Okay, so the mandible is the most common site and the origin is mostly from the cell rest of molasses. And squamous odontogenic tumor SOT is often mistaken with which tumor? They can ask you like that in MCQ. It is often mistaken to acanthomatous type of ameloblastoma or to that of well differentiated squamous cell carcinoma. Now coming on to next important MCQ, that is calcifying epithelial odontogenic tumor or CEOT. Calcifying epithelial odontogenic tumor or CEOT, otherwise known as pin box tumor. Okay, it is many times they have asked you in MCQ about CEOT. The other term they ask you pin box tumor. Okay. Now the origin of this is very important. CEOT origin is mainly from the stratum intermedium. So I hope you remember very well in oral histology lecture in development of tooth, you know what is stratum intermedium. They are the cells which lies between the inner enamel epithelium and outer enamel epithelium. So stratum intermedium is the origin, is the reason for origin of which tumor? CEOT. Okay, calcifying epithelial odontogenic tumor. The mainly it is derived from stratum intermedium, and the most common site is important. It is mostly seen in the mandible compared to maxilla. 2:1 times it is most seen in the molar region. Okay, so in the radiograph it is very clear, and the radiographical pattern of CEOT is very commonly asked in MCQ. It is driven snow appearance. So driven snow appearance. So what is a driven snow appearance? Can you see that black arrow mark in that radiograph? Okay, that is the centermost point, and from that centermost point you can see flecks of snow which is being driven from that particular center towards outside. Okay, it is similar to the second picture, isn't it? So that is why it is called as driven snow appearance. Okay, driven snow appearance. It is seen mainly in calcifying epithelial odontogenic tumor, and the main pathogenesis is it is derived from stratum intermedium. Most common site is mandible. Remember all these points. Now histologically we should remember two important points, MCQ points here pertaining to CEOT. One is it contains microscopically amyloid material. Characteristic microscopic feature of CEOT is amyloid, presence of amyloid material. Okay, in that I have given a red arrow mark. Okay, the first picture shows you the amyloid deposition in CEOT. Okay, that is important. And second important MCQ is the presence of calcifications are called as Lessig-Gang rings. So the second picture shows you the purple color. The arrow mark is pointing towards purple color, that is Lessig-Gang rings, the calcifications of the tumor. Okay, so the calcifications are shown there, and those calcifications are similar to the Lessig-Gang rings. Okay, the rings of sedimentary rocks. Okay, these are sedimentary rocks in the left side. Okay, in that sedimentary rocks you can see some rings, isn't it? So it is similar. That same pattern is depicted in the tumor also. That is why it is called as Lessig-Gang ring pattern. Okay, the presence of calcifications are also called as Lessig-Gang rings. Clear? So these are the two histological important MCQs which are routinely asked pertaining to CEOT. Now coming on to adenomatoid odontogenic tumor or AOT. Okay, adenoblastoma. It's very important MCQ. Okay, AOT, adenomatoid odontogenic tumor. There is formation of duct-like structures by the epithelium in this tumor. Okay, because of that reason the term is given as adenomatoid. The term is adenomatoid because there is formation of duct-like structures. Duct-like structures like salivary gland duct-like structures are present in the epithelium of this tumor. Because of that reason it is called as adenomatoid odontogenic tumor. Clear? And it mainly occurs in relation to an unerupted tooth, mainly in the anterior maxilla. So that is why in that clinical picture, can you see that lady with anterior maxilla, you have the swelling, and there is an unerupted tooth in that area. So it occurs mostly in relation to an unerupted tooth. Mostly the tooth will be a canine. Okay, and mainly the lesion is seen in the anterior maxillar region. So with the location you have to relate and study. So maybe they can give you a descriptive clinical features of a patient, and they can ask you to identify your provisional diagnosis. Okay, so you should remember anterior maxillar region, mostly found lesion tumor is adenomatoid odontogenic tumor in relation to canine. Okay, the canine will be mostly an unerupted tooth, and most of the times it is seen in females, that too below 20 years of old. Okay, 20 years of age. Okay, so females below 20 years of age, it is most commonly seen. AOT is mostly seen in females. Okay, and that too the site is anterior maxilla. Remember the location. Since the lesion is mostly seen in the anterior maxilla, that too in the canine area, now look into the first radiograph. You can see the roots, the divergent roots of laterals and the premolar in that particular area. Okay, can you make out? Okay, there is an unerupted canine in that area. There is an unerupted first premolar. There is a second premolar. The roots are divergent, and there is a lateral incisor, which is the roots are also divergent. Okay, so radiographically, all these things you can make out. There is a divergence of the roots and displacement of the adjacent tooth than root resorption. Okay, the roots will not be resorbed, but instead there will be divergence of the roots, and it is mostly seen in the anterior maxillar region as a unilocular radiolucency. Okay, and as I told you, as the name implies, it contains duct-like structures. Okay, and these duct-like structures are lined by an eosinophilic rim of varying thickness, which is called as hyaline ring. Okay, so that is given in the second image. Hyaline ring appearance is seen in the adenomatous odontogenic tumor surrounding the duct-like structures in the epithelium, and it is a classical feature in case of AOT. Now coming on to next important MCQ, that is odontoma. First itself, when I taught you about amyloblastoma, I had told you amyloblastoma is the second most type of common odontogenic tumor. So which is the first common variety? It is odontoma. So odontoma is the most common neoplasm which is reported till now, and it is actually what it is organization of odontogenic cells that fail to reach a normal state of morphodifferentiation. That is, there is no proper formation of enamel or dentine or pulp. Okay, there is no organized formation. So it can be of two types. Odontoma itself is of two types. As you all know, it is complex type and compound type. So the first one shows you the complex type. Okay, and it is appearing as radiographically, it is appearing as irregular mass. Okay, whereas compound variety is more of a tooth like, it is similar to a normal tooth like structure. So compound composite odontoma and complex composite odontoma, these are the two varieties of odontoma. Compound variety is similar to the tooth. Okay, so that is an important MCQ. They can ask you which type of odontoma is more similar to a normal tooth. It is which one? Compound odontoma. Tooth-like structures are seen mainly in compound odontoma, whereas in complex type it is more of a irregular mass. Okay, and among complex and compound type is more common than complex. Okay, compound type of odontoma is more common variety than complex type of odontoma. Now coming on to the location, maxilla is more commonly most common site compared to mandible. Okay, maxilla is more common site compared to mandible, and in case of compound odontoma, mostly they are seen in the anterior maxilla region, and complex odontoma is seen in the posterior maxilla region. If you take maxilla and mandible, the most common site is maxilla. Within maxilla, compound odontomas are mostly seen in the anterior maxilla region. Tooth-like structures are mostly seen in the anterior maxilla region, whereas irregular masses are more commonly seen in the posterior maxilla. That is, complex odontomas are mostly seen in the posterior regions of the maxilla. Okay, and radiologically, so as I told you, clinically they are of three types. They can be a central type of odontoma, or they can be a peripheral type, or they can be an eruptive type of odontoma also. Okay, and radiologically, as I told you, they appear as what? They appear as radio opacities surrounded by a narrow radiolucent band between the roots of the tooth. They are mostly seen. Okay, and compound odontoma are seen as numerous small tooth-like structures. Okay, so these are the important points. Now let's learn about the histological features. So coming on to the histology, the complex odontoma, there is a normal appearing enamel or enamel matrix, the dentine and the pulp. All of them is normal actually. Okay, there is normal appearance. There is no much abnormality, but the deposition and the formation is very irregular. That is the only thing. Okay, the appearance will be normal in case of an enamel or a dentine, and pulp in case of an odontoma. And among all the three, dentine forms the bulk of odontoma. Okay, so among all the three, enamel, dentine and pulp, most of the times the odontoma consists of what? Dentine. Okay, dentine forms the bulk of odontoma. And histologically, what you can see ghost cell appearance. Ghost cells, they are similar to calcifying odontogenic cyst and ameloblastic fibro-odontoma. Ghost cells are seen in odontoma. Okay, ghost cells, you can see characteristic ghost cells are seen histologically in case of odontoma. They are also seen in calcifying odontogenic cyst and ameloblastic fibro-odontoma. Coming on to next important type of odontogenic tumor, that is ameloblastic odontoma. In ameloblastic odontoma, there is simultaneous occurrence of ameloblastoma and a composite odontoma. So composite odontoma means it can be both types, compound also, complex also. Okay, and ameloblastic type of odontoma is mostly seen in children. Okay, you should note down that point. It is mostly seen in children. Okay, the ameloblastic variety which is seen mainly in children is ameloblastic odontoma. And histologically they are seen as three different types: basal cell, follicular and plexiform. So just note down, it is not frequently asked, but just note down frequently it is seen in children, and these are the histological varieties. Now coming on to next important tumor, both of them are variants of the same: calcifying cystic odontogenic tumor and dendinogenic ghost tumor. Okay, so as I told you, calcifying odontogenic cystic odontogenic tumor and dendrogenic ghost tumor are variants of calcifying odontogenic cyst. Okay, so COC is placed in calcifying odontogenic cyst is placed in tumor classification, as some of the variants consist of solid tumor with ameloblastoma like areas, dentinoid and ghost areas. So because of this reason, this form designated as dendrogenic ghost tumor or odontogenic ghost tumor. Clear? So which means in odontogenic cyst we had dealt about calcifying odontogenic cyst. So calcifying odontogenic cyst, because of its malignant some rare variations, it is now reclassified into two types. One is calcifying cystic odontogenic tumor and one is dendrogenic ghost tumor. Clear? When some calcifications are seen, it is placed under calcifying cystic odontogenic tumor. When dentine-like structures are seen, then it is placed under dendinogenic ghost tumor. Clear? So that is how it is being classified. Now, there is an unusual ghost cell keratinization of the odontogenic epithelium, which is a striking histological feature of this particular type of variety. Okay, so that is the ghost cell appearance is what is shown in that particular image. So ghost-like calcifications or keratinizations are seen. So this is especially seen in calcifying cystic odontogenic tumor and dendrogenic ghost tumor. And this type of cyst, okay, calcifying odontogenic cyst, shares some features with that of craniopharyngioma. Okay, it shares features with craniopharyngioma. Now, as I told you, there are two entities within this particular tumor. That is, one is the cystic portion and one is the neoplastic portion. So, cystic portion is the calcifying odontogenic cyst portion, and that particular lesion, if it's predominates, then it is called as calcifying cystic odontogenic tumor. Okay, whereas if the neoplasm part is more predominating in the particular tumor, then it is called as dendinogenic ghost tumor. So you understand the difference? The same particular tumor, if the cystic portion is more, then it is called as calcifying cystic odontogenic tumor, and if the neoplastic variant is more, then it is called as dendinogenic ghost tumor. So that is the difference. Understood? Now ghost cells, as I told you, they are seen in the particular tumor, and how do they appear? They have a shadowy appearance in histological sections. Okay, so ghost cells are called so because of their shadowy appearance in histological section. So these are the important points related to calcifying cystic odontogenic tumor and dendrogenic ghost tumor. So it is these two tumors are actually portion of calcifying odontogenic cyst itself. They are actually modifications of the cyst. And how does that modification comes? It is based upon the majority what it covers. If that particular tumor contains more of cystic part, then it is called as calcifying cystic odontogenic tumor, and if it contains more of dendrigenous part, then it is called as dendinogenic ghost tumor. Clear? And an important characteristic feature histologically seen in this particular tumor is ghost cells, and that is because of the shadowy appearance seen in H&E sections. Now coming on to odontogenic myxoma. Odontogenic myxoma is the radiological feature is only important for us in MCQ viewpoint. Okay, odontogenic myxoma, as the term implies, it contains both the epithelium as well as the connective tissue part. Okay, myxoma, that is the connective tissue part. So both the parts, it is having both the parts, and the most common location is mandible. And now the clinical picture I have shown, radiographical picture which I have shown there is actually the lesion in maxilla. So in that particular region, what you can make out radiographically, odontogenic myxoma characteristic appearance is that of a tennis racket appearance. So the down I have shown you the tennis racket. So can you make out the same characteristic pattern that of a tennis racket and in that radiological picture. Okay, so it is like compartments, isn't it? So that radiolucent areas are in compartments, like fine trabeculae arranged in right angles to each other. Okay, so because of this characteristic appearance like a tennis racket, how it is being arranged, so the same way it simulates, that is why the radiological feature of odontogenic myxoma is given as tennis racket appearance or a step ladder appearance. Okay, tennis racket or a step ladder appearance radiographically is seen in case of odontogenic myxoma. So remember all these points. Okay, odontogenic myxoma, remember MCQ wise only you have to remember the radiology part. Radiologically it appears as a tennis racket. The radiolucent areas are like the compartments in a tennis racket, okay, or a step ladder. So this particular feature is seen in odontogenic myxoma. Now coming on to the last benign odontogenic tumor which we are dealing today, that is cementoblastoma. It's very important because cementoblastoma or true cementoma or benign cementoblastoma, it is seen radiographically as dense radio-opaque tumor, okay, at the root portion of the mandibular molar is the radiographical picture I have shown there. So radiographically it is shown connected to that of a root portion of a tooth. Okay, and it's a true neoplasm of functional cementoblast, that is what you should remember. Okay, and it is mostly seen in mandible, 3 times more than that of maxilla, and the tooth most commonly affected is also first permanent molar. Okay, so that is why the radiograph is that of a first permanent molar, and the associated first permanent molar is vital. So that is a characteristic feature you should remember. In case of cementoblastoma, cementoblastoma is the neoplasm of cementoblast cells and is connected to a permanent tooth which is vital. Okay, and the tooth root is actually resolved in this particular case, and since it is related to cementoblast cells, it is seen in the root portion only. And it is, how does it appear? It appears as a radio-opaque, okay, and it is surrounded by a radiolucent border. That also you can see clearly in that radiograph. Okay, and cementoblastoma itself are of 3 types. One is cementoma, one is cementoblastoma, and the last one is gigantiform cementoma. Okay, so just learn those 3 types, that is enough. Okay, so MCQ viewpoint, they ask you mainly the true neoplasm of functional cementoblast is actually what they ask you. So it is cementoblastoma. The tumor which is odontogenic tumor which is associated with that of a vital tooth is also cementoblastoma. Answer is cementoblastoma. Okay, and the tumor which is mostly seen in mandible is also cementoblastoma, and the most commonly affected tooth is also first permanent molar in case of cementoblastoma. So this is a characteristic radiological appearance. So these are the benign odontogenic tumors. Okay, clear? Now coming on to malignant variety. So in malignant variety we have to learn only one lesion that is important in MCQ viewpoint, that is carcinoma X odontogenic cyst. Okay, so the most common odontogenic cyst to show carcinomatous changes is actually which cyst? The cyst is dentigerous cyst. Most of the times people make a mistake giving the answer as OKC, because OKC, as I told you in the explanations of OKC is having a very rash behavior. Okay, OKC is having a very transition changes are also high in case of OKC, but still when you compare with dentigerous cyst is the one which goes highest kind of carcinomatous changes. It changes into ameloblastoma, it changes into ameloblastic carcinoma, it can transform into squamous cell carcinoma. So all these transformations can occur in dentigerous cyst. So remember, the most common odontogenic cyst that undergoes a transformation is dentigerous cyst, not OKC. Okay, so that is the most important point you should remember. It is dentigerous cyst, not OKC, which is undergoing carcinomatous changes. Highest chances, okay, when you take the highest chances. Okay, so this is the last malignant tumor we have to deal MCQ viewpoint. So remember just this, okay. So with this we come to the end of this chapter. So part 1, part 2, part 3 we dealt about odontogenic cyst. Okay, that itself we divided into odontogenic and non-odontogenic cyst, and part 4. Okay, this lecture we dealt completely about odontogenic tumors, and that too we discussed only important points which is important for MCQ. Okay, so only that is being discussed here. Okay, so give stress to those points only. Okay, so thank you, keep learning, revise the lectures, that is more important. Relate and study with pictures. Okay, if you don't understand, do message. Okay, thank you.